As you can recall, this patient has a low expression of PD-L1. It was only expressed in 2% of the cancer cells. So we have several options. You could consider platinum-based doublet plus or minus bevacizumab. So the drugs of choice could be what this patient received, which is carboplatin, paclitaxel, bevacizumab. You could consider carboplatin pemetrexate with or without bevacizumab. There's data for that as well. You could also consider, although I would not recommend it, treatment as per Keynote 21G, which to use carboplatin, pemetrexate, and pembrolizumab. What concerns me about this patient and this specific drug selection is the fact that she has an active Crohn's disease. We know from our past literature that if we give immunotherapy to patients with active connective tissue disease, they have about 60% chance of recurrence of the connective tissue disease. The reason to add bevacizumab to carboplatin paclitaxel stems from ECOG 4599 clinical trial, which showed that addition of bevacizumab to carboplatin paclitaxel improves survival and improves response rate and progression-free survival compared to carboplatin and paclitaxel alone. In order for patients to be eligible for bevacizumab treatment, there are certain criteria that has to be met. Patients cannot have current bleeding disorders. It is recommended that patients do not have any history of hemoptysis. Patient cannot have an uncontrolled hypertension. In this specific patient, all of those criteria were met. Therefore, I believe that bevacizumab could have been added to carboplatin paclitaxel. In my personal experience, bevacizumab is well tolerated. There are certain side effects one needs to be aware of, specifically hypertension, proteinuria, increased incidence of clotting, and increased incidence of bleeding. And I believe it is very important to talk to our patients before we initiate bevacizumab to warn them about those side effects so they can be on the lookout for them as well. IMpower 150 was a randomized phase 3 clinical trials for patients with metastatic disease, untreated. The study randomized patients into 3 different arms. One was carboplatin, paclitaxel, bevacizumab. The second arm was carboplatin, paclitaxel, atezolizumab. And the third arm was carboplatin, paclitaxel, bevacizumab, atezolizumab. At this point, the only information we have is a press release telling us that IMpower 150 met its primary endpoint, which was progression-free survival, when compared a quadruplet arm, so carboplatin, paclitaxel, bevacizumab, atezolizumab, to a triplet arm of carboplatin, paclitaxel, and bevacizumab. We do not have any information on their degree of the PFS benefit. We do not have any information on the comparator of carboplatin, paclitaxel, bevacizumab, and carboplatin, paclitaxel, atezolizumab arm. At this point, I believe it is too early to make any treatment changes based on IMpower 150 results, but I am looking forward to learning more about the study and to understand what is the degree of benefit those patients received.